Everyone, I am Mehek and I will be talking to you about exocrine pancreas, liver, and gallbladder pathology. Let us start off with pancreas. So, pancreas is a retroperitoneal organ. It lies behind the parietal peritoneum along with kidneys, duodenum, rectum, and a couple of other vessels. It has a dual function, as in it has an endocrine function which releases hormones like insulin, glucagon, somatostatin via the islets of Langerhans cells into the bloodstream, and an exocrine function where it releases digestive enzymes into the duodenum or into the small intestine, helping with breakdown of carbohydrates, fats, and proteins. So the three main enzymes that I want you to focus on is which will help you in understanding the pathophysiology in the next couple of slides is amylase, lipase, and trypsin and chymotrypsin, which is collectively known as protease. All right. So protease, lipase, amylase. Okay. When they're in the pancreas, they're present as zymogens or inactivated enzymes stored in granules, which need to be activated when they enter into the small intestine. For example, trypsinogen and chymotrypsinogen, when they enter the duodenum, need to be broken down by enteropeptidase to form trypsin, which will break down chymotrypsinogen into chymotrypsin. So that is how it helps in aiding with digestion. With that being said, let's move on to the pathology. So the first pathology we will be talking about is acute pancreatitis. Itis refers to inflammation. So it's the inflammation and fatty necrosis of the pancreas. The main causes, two main causes is alcohol and gallstones. But for your knowledge, there is a mnemonic for the etiologies of pancreatitis because there are a lot of them. I get smashed. I will break it down for you. I means idiopathic cause. G for gallstones, E for ethanol, meaning alcohol, T for trauma, S for steroids, M for mumps, A for autoimmune pancreatitis, S for scorpio stink, H for hypertriglyceridemia or hypercalcemia, H for high. E again is known for ERCP, which is a diagnostic tool used to find lesions in the pancreas, in the gallbladder, etc. And D for drugs. Either ways, any of these causes can lead to three major reasons as to why we have inflammation. One is a cellular injury. When I say cellular injury, I mean specifically acinar cells are affected. If the acinar cells are affected, which basically secrete the digestive enzymes I was talking about, lipase, right? Lipase, amylase, and protease, right? So for acinar cells, if they get damaged, then none of these enzymes are secreted into the duodenum. They're not secreted in the duodenum. But if they're destroyed, these enzymes get released. And if they get released, there's only one place to go, around the organ and affecting the tissue of the pancreas. So that's one. The second reason is ductal obstruction. So if the pancreatic duct is stopped by obstructed by a gallstone, there will be a lot of backflow of all the enzymes that were supposed to go into the duodenum are now in the pancreas. And so what will happen then is they will stay there for a long time. That will lead to stasis. Stasis means no movement. And if there's no movement, there's a higher risk of these zymogen granules to come in contact with the lysosomes and lysosome enzymes or lysosomes lysosomes or the lytic enzymes present within the pancreas, hence releasing them again in the tissue and into the organ. So now that we've established that these things really lead to increased release of lipase, protease, and amylase in the organs, let's see what it does. When lipase is released, it leads to bulbar necrosis. What does that mean? Lipase breaks down fat. So in this case, it is going to break down peripancreatic and mesenteric fat. What would that do? First of all, it will lead to necrosis. Second of all, it would lead to release of the free fatty acids, which will bind with calcium found in the organ and lead to fat saponification, which is precipitation of these fatty acids combined with calcium in the already damaged organ tissue. And because the calcium is being used by the free fatty acids, there'll be hypocalcemia. This specific type of necrosis is known as bulbar necrosis. Remember this, right? And the second thing is what would happen if the proteases get into the pancreas. The protease will lead to destruction of the parenchyma. How? It will lead to destruction of the parenchyma first by erosion of blood vessels. All right, erosion or damage. Let's start with damage because that's a milder form. So there'll be damage of the blood vessels, which will increase capillary permeability and then increase capillary leakage, which means now the fluid is no more in the blood or in the intravascular space, but in the interstitial space, leading to edema and decreased blood volume. And also, another thing that I will add on here, I know it's getting a bit complicated, sorry, is the fact that acute pancreatitis is an inflammation, right? And when there's an inflammation in the tissue, inflammatory cytokines will be released. I will talk about interleukin 1, interleukin 6, TNF alpha. These three, always remember because they'll be important regardless. Anywhere you see inflammation, these cytokines come into play. When they are released, they not only increase the capillary leakage or the permeability, but they also lead to vasodilation. So now there's edema and there's decreased blood volume because the fluid has moved out, and there's vasodilation. That can only lead to one specific thing, and that is shock. In this case, distributive shock. So those are the two things that can happen in acute pancreatitis. I'm not forgetting amylase. Amylase is also present. It doesn't do anything specifically other than moving into the bloodstream. So when we are taking blood results, there'll be increased amylase. All right. Now, with all of that said, there are some clinical signs, right? Clinical signs would specifically mean pancreas is present in the epigastric region. So you will have pain in the epigastrium right after the digestion of food. Why? Because that's when we need the pancreatic enzymes. So that's when we will feel the pain. It's a positional pain, which means that if in a specific position, there will be a worsening or the pain will get better. If you lean back, you're stretching the abdomen so much that it might lead to worsening of the pain. But if you crouch ahead, it seems to help with the pain. Also, the fact that when there's inflammation, right, there's so much inflammation in the pancreas that it might lead to compression or pressure onto the duodenum, into the stomach, because the pancreas, I know, please bear with me, it is a bad drawing, but the pancreas is present and surrounded by the stomach, the duodenum, most of the small intestine. And if there's compression here, inflammation here, it's going to press and increase the pressure in the duodenum, rest of the small intestine, in the stomach, which will lead to feelings of nausea. If it gets worse, the food can't go down because there's decreased motility. So the food will go up, leading to nausea and vomiting. And because the patient's vomiting and has nausea, do you think the patient will want to eat? No. So there'll be anorexia. All right. I know it's a lot to take in. I know it got messy, but I hope this made sense. So we'll move on to the complications. There are specific, like any issue, if it goes on for too long, it can lead to complications. One of the complications we are the most scared about is necrotizing pancreatitis. which means that there's been so much liquefactive necrosis in the pancreas, and it's a very vulnerable tissue. And when there's necrotizing pancreatitis, it means that there is an infection. All right. So there's an infection which leads to septic shock. And therefore, and it usually occurs on the third day post acute pancreatitis attack. And so we need to be careful, and we need to keep giving the patient antibiotics, right? The second thing is this liquefactive necrosis. For if it keeps going on like this, and if this pancreatitis complication keeps going on, eventually, let's say this is the necrosis, there are two things that can happen. If it's necrotizing and there's still liquefactive necrosis, there'll start be an outpouching or fibrous, where there's a thick fibrous tissue around it. And if that happens, and the necrotizing tissue will start pooling in here, if it walls off, now it's just the necrotic tissue along with bacteria like E. coli, Klebsiella, Enterobacter, right? If that happens, it's known as an abscess. If it's simply liquefactive necrosis or liquefactive pancreatitis without infection, and you see an outpouching like this, right? Same thing, but an outpouching, thick fibrous capsule, more thick than the pancreatic abscess, and there's liquefactive tissue here, but there's no infection. It's called a pseudocyst because it looks like a cyst, but it's not quite. So it's a pseudocyst. And this will only present as an abdominal mass. So it'll cause the patient to have early satiety and have pressure against the stomach, but it won't have an infective or an infection in it. The last complication, very severe complication, and it only happens in the worst case scenarios, is hemorrhagic pancreatitis. So you know how I said the proteases cause erosion of the blood vessels? Now it doesn't just do it in the pancreas, but also outside the pancreas, which will lead to hemorrhage around the area. And if it gets too much, it will lead to a thromboembolic, like a thrombogenic state, which means that there'll be increase in procoagulation or procoagulative factors and a decrease in anticoagulative factors, which will lead to a lot of microthrombi being formed, loss of clotting factors, and that is called DIC. Another complication is ARDS. Again, a severe case. If, as I said, if there is too much fluid that is diffused out of the vessels because of increased capillary permeability. Now, this is a diffused issue. It doesn't just happen in one area with the pancreas, but it happens all over the body. So if in the worst case scenario, it reaches the lungs, the capillaries get increasingly permeable, or the blood vessels, get increasingly permeable, the fluid will go from the intravascular space into the interstitium of the lungs and into the lungs themselves, and that will lead to acute respiratory distress syndrome, which is an emergency, and therefore it's life-threatening. So we need to be careful about that. And the last complication is chronic pancreatitis, and we will be talking about that here. So chronic pancreatitis is basically chronic inflammation naturally and irreversible damage of the pancreas. Multiple causes of chronic pancreatitis, just like in acute. Chronic pancreatitis is caused because of recurrent bouts of acute pancreatitis. What happens is the acinar cells have gone through enough, right? They have had destruction, they have been attacked by lipases, proteases, amylases, and so they're atrophying now, they're dying. And like in any scenario, after inflammation, when there is neutrophils and macrophages coming in, there are also fibroblasts coming in. And what fibroblasts do is they lay down fibrotic and scar tissue in the damaged areas. And now this organ is not the same. It doesn't produce anything. It isn't doing the same functions because it's just fibrous tissue. There is no function. There's no regeneration. There's just patching up the work now. And it can also lead to stenosis and dilation of certain ducts. The second cause, and the third cause, chronic alcohol abuse and cystic fibrosis, they technically cause the same issue. They cause a plug formation. Chronic alcohol abuse increases the amount of bicarbonate and mucus that is produced, and therefore you have a plug. In cystic fibrosis, it's increased amount of mucus formation, right? And they form a plug, which leads to distension and obstruction of the ducts. Then there's also something known as hypercalcemia. Again, the same thing as in acute pancreatitis. What happens is it precipitates around the ducts, and it leads to distension of these ducts. These ducts can't push out any fluid, and there's like a lot of backflow. There's storage of everything that they're supposed to give to the duodenum. Autoimmune pancreatitis and idiopathic pancreatitis. The symptoms pretty much the same, except that now it's worse. There's chronic epigastric pain and there is malabsorption, because now usually when in acute pancreatitis you can see an increase in amylase or lipase, but you can't see that in chronic pancreatitis because the acinar cells have atrophied, which means there are no digestive enzymes. As there are no digestive enzymes, it will lead to malabsorption of carbs, fats, proteins, right? Naturally, when the inflammation keeps going on and on, it doesn't just affect the ducts, it doesn't just affect the acinar cells, it starts to affect the islets of Langerhans. And that's when you can have pancreatic diabetes and pancreatic insufficiency. Why will it be diabetes? As you all know, because there's a decrease in insulin. So chain of flakes over here that you can see is basically the finding that you have on imaging studies when you look for chronic pancreatitis. So I think that it's worthy remembering, and you will see it in the future. So I just added it on. So adenocarcinoma of the ducts is basically what happens. Either ways, it is the main risk factors are chronic pancreatitis and smoking. Adenocarcinoma, it can affect the body, the tail, or the head. Majorly, it affects the head of the pancreas. And if that happens, it can lead to obstruction of the bile duct that will lead to cholestasis. Cholestasis is no movement of the bile. If that happens, it can lead to obstructive jaundice. Obstructive jaundice caused by cholestasis, but jaundice in general is an increase in bilirubin levels in the body, could be conjugated, unconjugated, or both. If it's obstructive jaundice, what we will see is dark urine, pale stools, and pruritus. Dark urine, why do you see it? Because dark urine is caused when there is all the conjugated bilirubin, which either gets converted into stercobilinogen in the gut, in the GI tract, and gets pushed out in the stools, or else as urobilinogen in the kidneys and gives the yellow color of the urine. Dark urine happens when there's too much of conjugated bilirubin, which has now moved on to the bloodstream, gone to the kidneys, passed out through the urine. But because there's an obstruction, there's cholestasis, and this cannot lead to, there's no bile salts which can allow it to lead to be a part of the gut and move through or helps with the unconjugation. It cannot pass through the duodenum to the ileum, where it gets converted into stercobilinogen and gets pushed out in the stools. So now the stools are pale. There's also another sign that you see, that's Courvoisier sign, which is basically painless jaundice, and it means that you feel the gallbladder. It is huge, but it's palpable, but there's no pain. So that's Courvoisier sign. Pancreatic carcinoma presents with, usually it's asymptomatic, but if there is a pain, it will be epigastric, band-like pain. There'll be weight loss because it's a malignancy, right? And there'll be malabsorption because pancreatic insufficiency, or the pancreas aren't working. And migratory thrombophlebitis, which is very characteristic for pancreatic carcinoma, and it is also known as the Trousseau's sign. All right. Now, there are a few congenital anomalies that I'm gonna just brush through so that you remember them. There's annular pancreas, pancreatic divisum, and congenital pancreatic cysts. Annular pancreas is essentially the pancreatic tissue bands and surrounds the descending duodenum. as you know, there's the pancreas here, the stomach, duodenum, right? There's excessive pancreatic tissue that's partially or completely covering or forming a band surrounding the duodenum. Divisum means that there is a failure of fusion. So in embryo, according to embryology, when the pancreas are formed, there is the dorsal and the ventral part of the pancreas that need to turn, twist, and fuse together, right? And in this case, it doesn't happen. And this happens during the 6th or the 8th week of gestation. But in this case, it doesn't happen. And so there are two different parts and two different ducts of the pancreas. And the secretions drain mostly into the minor ampulla on their own. And then the last one is congenital pancreatic cysts. These are incidental findings and usually asymptomatic. They might be with a thin wall and of variable sizes. We will move on to gallbladder and biliary tract pathology. So before that, what does the gallbladder contain? It contains bile. It stores it within its pouch. And only when small intestine sends it a signal, which is it secretes cholecystokinin, there's contractions of the pouch, and then bile is secreted from the cystic duct through the common bile duct and into the ampulla. Bile helps with emulsification of the fat, which means it helps with fat absorption and fat-soluble vitamins. So now gallbladder, just remember, it does not make the bile per se. It's a part of it, but also the liver makes the bile which comes from from the right hepatic duct, the left hepatic duct, through the common hepatic duct, and then it goes into the gallbladder, and that's where it's stored. All right. It also helps with excretion of bilirubin and excessive cholesterol. If things mess up, what will you see? Biliary colic, which is a right upper quadrant pain, and obstructive jaundice. We have already spoken about that, right? Just touched on that. So the first pathology is gallstones. Why do gallstones happen? It happens because there's a supersaturation of either cholesterol or bilirubin. Or else there's a decreased amount of phospholipids, specifically talking about lectin or bile acids, which means that there is less solubility of the cholesterol and of bile. And so there's hypersaturated bile. Or if there's stasis of the bile, so that means there's too much time, and now the electrolytes or the electrolytes like calcium will bind with conjugated bilirubin or unconjugated bilirubin, mostly unconjugated bilirubin, and lead to gallstones. The major ones and the most important one that you need to know is cholesterol. Cholesterol is the most common one. It happens because there's hypersaturation with cholesterol. And now this cholesterol, usually when it stays in the bile, it can be taken up by bile salts and bile acids, and it's made soluble. But if there's too much cholesterol, even there's not enough bile acids, and so there's some sedimentation or some leftover cholesterol which sediments or forms cholesterol stones. If there's stasis of bile, it will almost separate, right? Just like, let's say, if you keep a solution or like a mixture of water and oil, and you've mixed it and you shook it, but then you kept it on the table, in some time you would see them separate, right? The water and the oil. And that's the same thing that happens when there's stasis of bile. Cholesterol separates from the leftover bile, and then that leads to stone formation or obstruction. Usually it is radiolucent, and in most cases it's radiolucent, and that is because there is there's no light or any imaging that it can take. That means it is a patch of darkness. You can only see acoustic shadows. The second one is bilirubin. Now, it's surprising, right, that there is unconjugated bilirubin present in the bile, because usually it's conjugated bilirubin. But if there's too much hemolysis occurring in the body, regardless of what is the case, there's too much unconjugated bilirubin that is also being secreted out and coming into the bile. And now if that happens, this unconjugated bilirubin, so usually the bile salts or the bile acids take the calcium. Bile has bile salts, has phospholipids like lectin, it has cholesterol, conjugated bilirubin, in this case unconjugated bilirubin too, and it has electrolytes, specifically calcium and water, and also it has bicarbonate, right? Electrolytes like bicarbonate. So usually the bile salts bind to the calcium so that the conjugated bilirubin does not take it and form stones. But when there's too much unconjugated bilirubin and conjugated bilirubin, bile salts can't take up everything, right? So what they do is this calcium is taken up or stolen, as I've written it here, by unconjugated bilirubin, and now they become stones. Last one that you need to know is brown stones, and it's a special kind of stone. It usually and always happens because of bacterial infection, for example, because of E. coli, Klebsiella, Clostridium. And what it does is they bring out hydrolytic enzymes, these bacteria, they bring out hydrolytic enzymes which cleave the conjugated bilirubin and they cleave the bile salts. And the residual product of this cleavage or this process of cleaving leads to a product that can actually bind with the calcium, or that can actually bind with the free calcium that has been released because of cleaving. And so now they form calcium bilirubinate stones. So when you see brown stones, it's always bacterial infection. Most common stones, cholesterol. If they are black, bilirubin. Because of what? Unconjugated bilirubin. The risk factors: in women, it's higher because of in obese people, it's higher because of increased cholesterol levels. Rapid weight loss is higher because there's increase in the amount of bile produced. It's more common in women because of estrogen. All right. So depending on where these stones land, it could land within the gallbladder. So they could be within this pouch. Sorry. If they're in the pouch, they're called cholelithiasis. If they're stuck here, if there's too much, so there's going to be constant contraction, right? Because the small intestine doesn't know that the gallbladder has stones. So it's going to keep secreting cholecystokinin to keep compressing the gallbladder to put out bile. And one stone comes out and it migrates to the duct. And that's known as choledocholithiasis. Cholelithiasis in the gallbladder, choledocholithiasis in the common bile duct. Why does this happen? Supersaturation, decreased phospholipids, and stasis, right? Choledocholithiasis because it migrates to the duct. Cholelithiasis usually asymptomatic, but if it's symptomatic, biliary colic. Choledocholithiasis, on the other hand, as I said, there is an obstruction. The bile cannot go out. What does it cause? Cholestasis. And if that happens, it leads to obstructive jaundice, right upper quadrant, or epigastric pain, right? So there are certain complications, and we're going to talk about all these complications, but these complications are acute and chronic cholecystitis, inflammation of the ducts, ascending cholangitis, infection of the duct, gallstone ileus, which is basically decreased movement, which can lead to obstruction, and gallbladder cancer. So starting with acute cholecystitis. Acute cholecystitis is basically an acute inflammation of the gallbladder. It can be calculus. Calculus is the main type, and it's because of a stone. Acalculus is without a stone. I've written it right here. It's without a stone. It's mostly caused because of stasis or because of reduced perfusion. Sorry. Reduced perfusion is the main one. So it's an ischemic injury. Usually it's an ischemic injury. There's decreased amount of blood supply. So because of hypoxia, it can also lead to inflammation and damage. Secondary to multiple organ failure, trauma, sepsis, or prolonged fasting. All right, going back to the calculus. Calculus cholecystitis is caused because there's a stone in the duct. What happens? There's dilation because there's backflow. This dilation, there's too much pressure eventually. Initially, this bile that is staying in the gallbladder will affect the mucosa, start affecting the mucosal cells, leading to inflammation. There might be some bacterial overgrowth or bacteria that's present in there, usually E. coli. And pressure ischemia. What is pressure ischemia? There's too much pressure in the gallbladder eventually, which leads to compression of the blood vessels around it or supplying it, and that could lead to ischemia. So when all of this happens, what are the symptoms? I would have right upper quadrant pain, as I said, postprandially. Again, we need food to come in for CCK to be secreted by the small intestine and for the gallbladder to start contracting for the pain. If there is infection, there might be leukocytosis and fever. But usually the patient doesn't feel like eating. The patient feels like vomiting and nauseous because there's, first of all, pressure ischemia, there's too much inflammation, and there's no digestion happening per se, right? So the patient might show on a physical with a positive Murphy's sign. What is a positive Murphy's sign? So when you place your hand on the abdomen and you're holding all the organs in the right place, and you ask the patient, the gallbladder, the liver, and all of it, you have held it up, so there's no movement or so no friction happening, right? But when you ask the patient to inhale, take a deep inhalation, it might cause the liver to move and exhale. When the patient inhales and then exhales, the liver might rub on top of the gallbladder, causing a frictional pain. And that's a positive Murphy's sign. There'll be there'll be a rise in alkaline phosphatase, which is very characteristic for gallbladder injuries. And there'll be an increase in conjugated bilirubin. Why? Because that's the one that you find in the bile, right? If the inflammation goes on for too long, as there's pressure ischemia, too much pressure, dilation, it can also lead to rupture. So we need to be very, very careful, and we need to give antibiotics in case there's bacterial overgrowth. All right. Moving on to chronic cholecystitis. Acute bouts of cholecystitis and irritation of the gastric mucosa, the gastric and the gallbladder mucosa. Let's be more specific. The gallbladder mucosa, because of cholelithiasis or choledocholithiasis, can lead to chronic inflammation of the ducts. It will be the same features as acute cholecystitis. There'll be pain postprandially, can lead to nausea, vomiting, and fever, just a bit mild, and it is self-limiting. And on histology, specifically, we can see something known as Rokitansky-Ashkoff sinus, which basically means, okay, let's say this is the mucosa, all right? There is mucosa, lamina propria mucosa over here, the muscularis, and then the serosa, right? Rokitansky-Ashkoff sinus is basically outpouchings of this mucosa into the muscularis layer. So over here, you'll see these outpouchings that will come in here of the mucosa. What else will you see? Another thing that you will see is there'll be, because it's an inflammation, right? You will also see mononuclear infiltrates in the lamina propria. All right, so you will see Rokitansky-Ashkoff sinus, which is basically outpouchings of the mucosa into the muscularis layer, and you will see infiltrates, specifically neutrophil infiltrates in the lamina propria mucosa. Chronic cholecystitis quite often leads to porcelain gallbladder. And what is that? It is fibrosis and calcification of the inner wall. So the inner wall of the gallbladder, all of this, because of the chronic inflammation, it gets calcified, it gets fibrosed. Remember how I said after inflammation, along with neutrophils and macrophages, this usually with inflammation, the cells that also come in are fibroblasts. So again, fibroblasts will lead to fibrosis and calcification. So now porcelain gallbladder, essentially Why is it called that? Is because there's a shrunken hard gallbladder. And this is one of the main criteria or main risk factors, as I would say, for gallbladder carcinoma. All right. So this is bad news and this is scary, right? Moving on. Let's talk about cancer. There are two specific forms of cancer that we want to talk about here. There's gallbladder cancer and there's cholangiocarcinoma. Gallbladder cancer, adenocarcinoma of the glandular epithelium, just like pancreatic cancer, it's an adenocarcinoma. Major risk factor, gallstones, cholecystitis, porcelain gallbladder. All right. This presents as, again, obstructive cancer and weight loss of malignancy. Remember, usually with malignancy, you will see weight loss. Another one is cholangiocarcinoma. It's a well-differentiated adenocarcinoma, but this is of the bile duct. It can be the cystic duct or it can be the common bile duct. And if it's the common bile duct, or if it's around at the other hepatic ducts, like the right and the left hepatic duct, it's going to be extrahepatic. Otherwise, it's intrahepatic. If it's extrahepatic, there are two major causes, Clasticin tumor and distal extrahepatic. The main one is Clasticin tumor, which is one of the most common ones. And what happens is Clasticin tumor is, you know, the confluence I was talking about with the right and the left hepatic duct that forms it and then goes to the cystic duct right here. This is the common bile duct. At the confluence here is where you will see Clasticin tumor. It's very common and it's one of the most common actually. So you should know this one. And the risk factors for cholangiocarcinoma, again, chronic cholecystitis leading to porcelain gallbladder can also cause this, and cholangitis, primary sclerosing cholangitis. So finally, we're talking about the last two complications of gallbladder stones, and that is cholangitis and gallbladder ileus. Gallbladder ileus is essentially a decrease in movement. So there's a decreased movement or motility of the gallbladder. It's called mechanical ileus due to the obstruction caused by gallbladder stones. What happens is the gallbladder stones lead to too much obstruction, so there's increased pressure. And now, as I said, there's a risk of perforation because the gallbladder keeps getting huge and huge, right? And it keeps getting huge, more huge. And when it gets too huge, it can actually lead to a perforation or rupture, right? Okay, this is a rupture, right? So that will lead to perforation or a fistula formation between the adjacent gut and the gallbladder. So that means now the stone has gone into the bowel, right? And that can lead to decreased movement and ileus. Most commonly, it's seen in the terminal ileum or the ileocecal valve, and the patient presents with abdominal pain, distension, nausea, and vomiting. Last one, cholangitis. Again, infection of the ducts, usually bacterial, the enteric gram-negative bacteria, right, like E. coli, Klebsiella, etc. The symptoms for this one specifically are present as Charcot's triad, worst case scenario, Reynolds pentad. This is my version of it. I have written it I said I did it as a triangle because of Charcot's triad. So the first one would be right upper quadrant pain, obstructive jaundice, and fever. If it gets too bad, Reynolds pentad, I will also have altered mental status and a septic shock. Why? Because there's bacterial infection, right? And sepsis can lead to altered mental status and septic shock, both. That's the worst case scenario, all right? So with that being said, the last and the final congenital issue of gallbladder is biliary atresia. Because of some reason, whatever reason, atresia is absence, essentially. It's an absence of a thing. In this case, the bile duct. It's the absence or the early destruction of extrahepatic biliary tree, most commonly the common bile duct. And it usually happens either because of an autoimmune issue or because the child is born that way. And so it presents as jaundice in neonates within the first 2 months. All right. And so it presents as acolic stool, dark urine. Again, why? Because the bile cannot move, cholestasis, and hepatomegaly. So there's discontinuity of the biliary system due to obliteration or fibrosis. That means cholestasis. That means, again, biliary cirrhosis and portal hypertension, worst case scenario, because hepatomegaly can lead to increased pressure in the portal vein. All right, so we have finally reached to liver, which is the last part of the pathology topic for today. Liver, basic outline, it has the blood supply is 2 inputs and 1 output. The 2 inputs, portal vein, which gets blood flow from the intestine and it's nutrient rich. Hepatic artery, blood from the heart, and it's oxygen rich. So this supplies the liver. The liver helps with detoxification and absorption. All right. And hepatic vein, which is the output. Function, as you all know, detoxification. It'll help with, I wouldn't say bile storage, but more like bile production is important. It has Kupffer cells, which help with erythrophagocytosis. That means that when erythrocytes, as in RBCs, break down, they form heme and globin. Heme gets broken down into biliverdin and Fe2+. Biliverdin gets converted to bilirubin, which is unconjugated here. It gets conjugated in the hepatocytes using guanyl transferase, and it forms conjugated bilirubin, which then proceeds into the gut and into the blood flow. So that helps with erythrophagocytosis, and there are also immune cells, which is an important part of the immune system. Moreover, liver produces coagulation factors, specifically coagulation factors which are vitamin K dependent. It also aids in absorption of vitamins. I remember this as 12 abs make a deck, which means A for vitamin A, 12 abs B12, vitamin B12, deck, vitamin D, E, C, and K. And it also produces albumin, which is very important as a carrier protein in the body. Now, I will start off with jaundice because jaundice is one of the most common clinical presentation whenever you have any pathology with the liver. Not the most common, it's always there it's always there, right? What is jaundice? It happens because there is too much bilirubin, which in the next couple of slides we'll talk about if there's an increase in unconjugated bilirubin, that is, there is an issue of too much production, too much unconjugated bilirubin and conjugated bilirubin, which means there might be an issue with the hepatocytes because they're responsible for this binding. Increase in only conjugated bilirubin, which means it could be an issue with the bile, right? Because that is where this conjugated bilirubin goes. Increased bilirubin is eventually causes yellow discoloration of the skin and the mucosa because they go and deposit there. Instead of just staying, they go and deposit. So one of the earliest signs that you would see would be scleral icterus, which is when the bilirubin level is more than 2.5 milligrams per deciliter. This is a very important value. Remember this. You will see scleral icterus. This is an important point in general. So jaundice can either be caused because of an increased production of bilirubin or a decreased clearance of bilirubin. Why do you have an increased production? Increased hemolysis. As I showed, RBCs break down into heme, globulin, biliverdin, bilirubin, which gets unconjugated, conjugated, right? And decreased clearance of bilirubin is because of either defects in transport or conjugation. So there's defect in the way it can go from the right hepatic duct down, or there's a problem with the conjugations in the hepatocytes. We'll see right now that it can happen because of a few congenital issues, and it can also be because of cholestasis. This is also could be because of transport, but it's obstructive jaundice in a separate category, right? So finally, moving on to the causes. If it's hemolysis, it can be intravascular in the blood or extravascular, which will be because of some defect, like it would be because of G6PD deficiency. What does G6PD do? It basically causes, it's glucose 6-phosphate dehydrogenase, and it produces something known as NADPH, which is basically the protector of RBCs against oxidative damage. So if there is decrease in this, the RBCs will be more prone or susceptible, right? Membrane defects like spherocytosis, sickle cell anemia. Essentially, sickle cell anemia is when you have these crescent-like RBCs. Membrane defects like spherocytosis essentially just means that you're having weak, fragile RBCs. Either ways, they cause an increase in hemolysis because they're not perfect or they're not the right RBCs. TTP and hemolytic uremic syndrome. So TTP is thrombocytopenic purpura, and hemolytic uremic syndrome. The reason why they cause hemolysis is they increase the amount of clots, microthrombi formation in the body. When that happens, let's say this is the blood vessel and there's a clot here, and the blood is trying to go normally, and one RBC, it hits this clot and moves on. It's gonna have a defect. It's gonna be a dent. And then if it hits another clot, let's say over here, and this hits another clot, it's gonna break down more. And this just leads to breakdown and increased hemolysis. We're going to talk in the next slide about defects and transport or conjugations. I'm not touching on that now. And then there's cholestasis, which can be intrahepatic or extra. Intrahepatic is when there's too much inflammation, hepatitis, cirrhosis, fibrosis or damage of the cells of the hepatocytes, and primarily biliary cirrhosis, which we read about, right? Extrahepatic is when there's choledocholithiasis or cholangitis, or if there's a malignancy, as we saw, obstructive, or if there's any biliary atresia, right? And then let's move on to defects in transport or conjugation. The main ones we're going to talk about is Gilbert syndrome, Crigler-Najjar, Dubin-Johnson, and Rotor syndrome. So Gilbert syndrome is inherited. All of them are inherited. This is again an autosomal recessive disease, and what happens is it's in which there's an increased impairment of intrahepatic conjugation of the bilirubin and glucuronic acid. So, and usually when you see a patient with Gilbert syndrome, the patient will have a history, or a patient with jaundice, right, would complain that the jaundice is periodic or it randomly comes. And this happens because of stress. So if the patient's sick, or if the patient's overexerting, or if the patient's dehydrated, you will see jaundice. And it causes like increase in unconjugated hyperbilirubinemia because we cannot conjugate this bilirubin. Crigler-Najjar is, again, what it causes is an autosomal recessive disorder. Why? There are two types. There's 1 and 2. The first type is when there's an absence. The second type is when there's a reduced activity of the glucuronyl transferase enzyme. If that happens, again, it'll have severe unconjugated hyperbilirubinemia. So Gilbert syndrome and Crigler-Najjar causes unconjugated hyperbilirubinemia. That means increased unconjugated bilirubin in the blood. Dubin-Johnson and Rotar both are benign, are characterized how? By increased conjugated hyperbilirubinemia. They are increased conjugated bilirubinemia and bilirubin in the urea. The problem is with the transportation, not with the conjugation. The difference is, in Dubin-Johnson, you will see a blackish brown pigment in the liver, and you might see normal urine coproporphyrins, which is the opposite in Rotor. You won't see any pigment, and you'll see an increased level of these urinary coproporphyrins, right? So that is all about congenital ones and the congenital syndromes. Gilbert, Krigler-Najjar, problem with conjugation, so unconjugated hyperbilirubinemia. Dubin-Johnson, Rotor, problem with transportation through the canaliculi, so conjugated hyperbilirubinemia, or the one that you find in the urine, bilirubinuria. Finally, we will move on to the cholestasis intrahepatic causes, and that is initially, and the main one, that is cirrhosis. Cirrhosis, a very common cause. It's an end stage liver damage. So if it's end stage, it will be irreversible, right? There is diffuse damage. So as you can see here, there's diffuse fibrosis and there's diffuse scarring. Etiology can be multiple things, but there's alpha-1 antitrypsin deficiency, which means there's increase in elastase. Budd-Chiari syndrome, when there is increased portal hypertension due to a tumor obstructing it. Cystic fibrosis, infection like hepatitis, hepatotoxicity because of alpha toxin from Aspergillus fungi, or else alcohol can cause it. So what happens? First of all, there's degeneration and necrosis of the hepatocytes. Why does that happen? There's the Kupffer cells, as I remember how I spoke about the immune cells, Kupffer cells, they get activated when let's say there's an infection or hepatotoxicity. They get activated, immune cells, immune response is mediated, which causes damage of hepatocytes. At the same time, they activate the hepatic stellate cells and they also cause inflammation. So 3 things they do. Hepatocytes activate the hepatic stellate cells, which are like fibroblasts, and promote inflammation. Inflammation is promoted. Remember how in acute pancreatitis I was talking about how there's a secretion of inflammatory cytokines or a release. So interleukin 1, interleukin 6, specifically over here we're talking about TNF alpha. And so these cytokines are released and they cause further damage of the hepatocytes because they lead to more inflammation, more capillary permeability, more destruction. And the activation of the stellate cells results in collagen formation. So now there's degeneration and collagen formation, degeneration and necrosis, and the stellate cells that were present, they cause fibrotic and regenerative nodular tissue to be produced. The damage triggers a repair cascade. Mostly in all situations, it's simple once you understand that whenever there's inflammation or there's damage, there will be a repair cascade, which is not that there'll be a regeneration because that's kind of impossible. So what the cells do next is they reconnect to some degree. They form connective tissue in the organ, leading to fibrosis. They just want to patch things up, be the function even if the function's not the same. So you have excessive damage, excessive formation of connective tissue, and this fibrosis can get so extensive that it goes into the periportal area and the centrilobular area, and this causes compression of the sinusoids, of the venules, of the portal venules and sinusoids, leads to increased hypertension. So now there's so much hypertension in the sinusoids too that the sinusoids stop functioning. So now you have damaged and necrotized hepatocytes, you have fibrotic tissue, and now you have decreased functional sinusoids. If that happens, there's impaired exchange of substrates. There's nothing that they can do. They cannot absorb any vitamins. They cannot produce any coagulation factors or any vitamins. Any albumin. They cannot even detoxify any substances. So there's a complete loss of the liver function. And do you see these nodules here? I found this really cute picture, and these nodules are the regenerative nodular tissue. So when you see hepatic cirrhosis, there's a chance that you might find on physical exam hepatomegaly with a lot of these nodular irregular border at the bottom. So as I said, cirrhosis can be caused because of multiple issues, right? The next pathology we're talking about is non-alcoholic fatty liver disease. It happens in 4 stages. It starts with steatosis, which is basically increased fat accumulation. Steatohepatitis, which means fat accumulation and inflammation of the liver. Fibrosis, again, damage causes a repair cascade, causes fibroblast to lay down fibrotic tissue. And cirrhosis, finally, because that is the end stage liver damage. Non-alcoholic fatty liver disease is associated with metabolic syndrome, which, if you already don't know, it comprises of hypertension, hypertriglyceridemia, diabetes mellitus, hyperlipidemia, and obesity. What happens is, because of an unknown reason, we don't know why, but it's associated with metabolic syndrome. So we are assuming there's an insulin resistant state that develops. When that happens, it means that now there's a promotion of or increase of fat storage, but there's a decrease of fatty acid oxidation, right? And so that will lead to steatosis. That means increased uptake, but decreased secretion will lead to fat droplets depositing in the hepatocytes. This fat doesn't just sit there. Eventually, it reacts with oxygen radicals ions, and this is what leads to the hepatitis, the inflammation and death of cells. Chronic inflammation or too much inflammation will lead to fibrosis, and this fibrosis chronically will lead to cirrhosis. Until it's advanced, so until the steatohepatic phase, this part is reversible. Beyond this, it's irreversible. So if we made any changes in the diet, lifestyle, and changed controlled my glycemic levels, had a weight control my cholesterol, my blood pressure, there's a chance I will not progress to cirrhosis. And usually because of that case, it's usually asymptomatic too, until it reaches fibrosis, cirrhosis, then there's hepatomegaly, post-hepatic jaundice, ascites, and pain in the abdomen. When this happens, when there's a damage, remember this, when there's a damage to liver, there are 2 enzymes that you need to remember is ALT and AST. Aspartate transferase, alanine transferase, And in this case, because there's damage to the liver, there's going to be an increase of both. Until the steatohepatitis phase, the liver appears large, soft, yellow, and greasy. But once it reaches the fibrosis and the cirrhosis phase, nodular, scar tissue, hard. All right. Next one. We spoke about non-alcoholic. We'll talk about alcoholic-related fatty liver disease. What happens is, alcohol or acetaldehyde, it comes in, and let's say there's alcohol is broken down by the liver into acetaldehyde, and it needs alcohol dehydrogenase to do so. All right. And it also needs, along with that, NAD+, which forms NADH in the end. So when you have too much alcohol, too much of it is broken down into acetaldehyde, and there's too much NADH produced. NADH promotes fat accumulation. NAD+ decreases oxidation of free fatty acids. This promotes free fatty acid production. This decreases the oxidation. So in the end, you have fat accumulation leading to steatosis. There's damage to the parenchyma because this does not only lead to a lot of acetaldehyde being produced, acetaldehyde also causes increased amount of oxidative damage, reactive oxidative damage, leading to inflammation, so alcoholic hepatitis. And it also causes, so acetaldehyde, when it doesn't just sit there. Too much of it leads to, it binds with macromolecules or molecules in general. It binds to it, forming new bodies which are known as adducts, acetaldehyde adducts, and this elicits an immune response. All right, and this activates an immune response, hence further leading to inflammation and damage of the cell. On a slide, what are you going to see? You're going to see a formation, it's very characteristic, formation of Mallory bodies, which are irregular, rope-like eosinophilic strings, cytoplasmic strings that you can see as in the cell. And there's perivascular fibrosis, that is fibrosis around the portal vein. So when you see a cell, let's say there are multiple cells, you might see fat accumulation, which is like, it's very clear, it is just completely transparent. And then there is formation of Mallory bodies, which is just aggregates of like these string-like eosinophilic bands that you can see. And perivascular fibrosis around the portal vein. Naturally, all of this will lead to hepatomegaly, that is increased size of the liver, and it'll be painful because this can lead to inflammation. Again, elevation of AST and ALT would be there, but in this case there'll be an increase of AST more than ALT. Then the next one is Wilson's disease that I want to talk about. Wilson's disease is caused because there's an autosomal recessive defect in the ATP7B gene. What does the ATP7B gene do? It's responsible for two things. It's responsible for the copper, usually in the hepatocyte. This is the hepatocyte. Copper comes in and it needs to be bound to the apocelluloplasmin, and it can only bind because of this ATP7B gene. So it binds 6 molecules, and the leftover copper is outpouched and excreted, and this is exocytosis. So when there's no ATP7B gene, there'll be lack of copper transport into the bile. This goes to the bile. And lack of copper attached to the celluloplasmin. So now there's an increased buildup of copper, and that leads to two things. Increased levels of copper leads to deposition into the liver, the brain, and the eyes. And it also leads to oxidative damage. It leads to free radical being produced and leads to oxidative damage. Because of the deposition, you can see cirrhosis. Wilson's disease leads to cirrhosis. Neurological manifestations, because it goes to the brain and it can deposit in, let's say, the basal ganglia, causing Parkinsonian symptoms or syndrome. It can deposit in the eyes, leading to Kayser-Fleischer ring that you can see in the eye. It's like a copper-colored ring. It looks pretty, but you know it's Wilson's disease. Increased risk of hepatocellular carcinoma is there because of Wilson's disease. And so what you do to remove this excess copper, you give D-penicillamine, which will chelate the copper. All right. So the next one, and one similar to Wilson's disease, is 1 minute. Yes. The one similar to Wilson's disease is hemochromatosis, which is excess iron in the body. It usually happens in men because women lose a lot of this iron and blood because of menstruation on a daily basis. And etiology, it's either genetic or because of frequent blood transfusions. Genetic because it'll be autosomal recessive. There'll be a mutation in the HFE gene in chromosome 6. What you need to know is that HFE gene regulates how much iron goes into the bloodstream. So if there is no gene that regulates it, too much iron's going into the bloodstream and too much iron's going into the enterocytes. So the iron, once it's taken in by the gut, but it's lost through the sweat glands, skin cells, and GI cells. In the GI specifically, it will sit in the enterocytes. If needed, go to the serum. If not, it's deposited along with ferritin in the form of hemosiderin. So when there's too much, naturally it deposits in different organs. Too much iron deposits in different organs. Specifically, the ones we need to worry about is liver, skin, pancreas, very important because we're going to see something about it, and heart. And when that happens, the process is called hemosiderosis, and liver damage will lead to cirrhosis naturally. Skin, too much of it will lead to deposition, causing hyperpigmentation, almost like a bronze color. We call something known as bronze. Diabetes can be an issue, which is when you have hyperpigmentation and also hyperfunctioning of the pancreas, exocrine, and endocrine functions because of deposition of iron. It can also go to the heart and lead to cardiomyopathy, and it can go to the brain, go to the pituitary gland, and cause anterior pituitary hyperfunction. So how will you diagnose it is using genetic testing naturally and getting a liver biopsy. Viral hepatitis. The next topic is viral hepatitis, and this is a big chunk, so just be prepared. Viral hepatitis is an inflammation of the hepatic tissue, mainly caused because of the hepatitis viral group, but it can also be because of EBV and CMV. I will specifically be talking about the hepatitis viral group because that's the most common and most dangerous at times. It can be acute viral hepatitis, which is it's less than 6 months of onset, progression, and disease. If it's more than that, it leads to chronic hepatitis and then damage. It can affect, so the liver, as you can see over here, I have had a lobule which has like a smiley face on it. But either ways, there are 3 zones of the liver. There is the pericentral zone, the transitional zone, and the periportal zone. The periportal zone has the bile duct, the vein, the artery, right? So going on, usually any damage, this is high yield, but usually any damage that is like caused because of alcohol. So zone 1, 2, 3. Alcohol or toxins affect zone 3 and downward. Hepatitis, that is an inflammation, goes from the periportal zone inwards. So on the slide, you would see something on histology, you would see something as a ballooning degeneration, cell death and necrosis. There'll be mononuclear infiltration in the panlobular mononuclear infiltration because the inflammatory cells are trying to enter in, like macrophages, neutrophils, and try to fight the infection in this zone, in the lobules. Councilman bodies can also be seen on histology. You remember how in alcoholic disease I said AST is higher than ALT? Well, look here. ALT is higher than AST in viral hepatitis. So that's one thing that you can check for. Here, it's a high yield table. You need to remember most of it. So just be careful a bit. I would recommend coming back to this table. There are 5 hepatitis viral agents: Hep A, B, C, D, and E. Other than hepatitis B is a DNA virus. Others are RNA viruses. Hepatitis A and hepatitis E are fecal oral routes of transmission. So you can remember it that way. While the others are either parenteral, so blood-borne, route of transmission, or sexual transmissions. So usually, which groups are affected? I'm going to start with A, all right? I'll do A and E first because they're both fecal oral. A affects travelers or daycare workers. The incubation period is 3 to 6 weeks. It's one of the main cause, the most common cause of acute hepatitis, can lead to hepatomegaly, and can also cause aversion to smoking. Serology finding is very important. It's a self-limiting disease. You need to know it's a self-limiting disease. So it never progresses to chronic hepatitis, and it does not have a carrier state, which means there are no individuals that just have the virus and transmit it without showing symptoms. Serology, I would look for anti-HAV IgM immunoglobulins and IgG. IgM is for active infection, IgG is for prior infection. It states it's prior infection or a vaccination. Hepatitis E, similar, fecal oral. This happens because people are traveling to waterborne epidemic regions. So regions where there's contaminated water or undercooked food. Seafood is where you would see hepatitis E viral infections. So like people traveling to Asia, Africa, Middle Eastern areas, which are waterborne epidemic regions. The incubation period is 6 weeks. And again, it's a self-limiting hepatitis in healthy individuals, that is. It's usually self-limiting, doesn't cause too much, and it does not progress to any hepatocellular carcinoma or chronic hepatitis. But there's an exception. A very huge exception is pregnant women. If pregnant women are exposed to hepatitis E virus, it can lead to fulminant liver failure, which is an emergency, and can lead to proper liver damage. We will look for serology if in the asymptomatic phase, HEV RNA virus, RNA on the serology. Otherwise, when there's a proper infection going on, active infection, IgM, and later IgG. All right. Moving on to HBV virus, which is blood-borne. It's a DNA virus. It can most commonly be seen in IV drug users, any blood transfusion or needle stick transfusion or accidents. It's also torch infection. A torch infection happens in women who are pregnant. So infection that are there in pregnant women and can pass down to the baby. It's known as vertical transmission, and the way I remember is because the woman gives birth in the downward direction. You can say it's a vertical transmission. Everything else is horizontal transmission. So even sexual transmission is horizontal. So sexual and blood transfusion, bloodborne is horizontal. Torch infection caused because of a pregnant lady through feeding or through delivery is a vertical transmission. The incubation period is a bit more. It's 30 to 180 days. And it can cause acute hepatitis. It can present in 3 forms, basically acute hepatitis, chronic hepatitis with or without cirrhosis, and fulminant liver failure. All right. For serology, it's quite a mouthful for Hep B virus. There's HBsAg virus, which is antigen, which is basically an antigen that is found on the lipid covering of the virus. And an anti-immunoglobulin against this is anti-HBs antigen. There's HBC antigen, which is core antigen. And against that there's a plasmid core, that is protein capsid core, that is present, and that HPC antigen it signifies that. And against it would be anti-HPC. And the last one, it's anti-HBe virus antigen, which is present between the lipid covering and the plasmid protein capsid core. All right. The next one, HCV virus, again bloodborne due to IV drug users. That's both for HCV and HDV. Now, HCV incubation period 2 to 6 weeks. It can either be acute or it could be chronic. And chronic is very important. It's a stable chronic infection which can go on to cirrhosis and hepatocellular carcinoma. So we need to be careful about that. We will see anti-HCV antigens, and HCV RNA test is the gold standard. Delta or hepatitis D virus, bloodborne, IV drug users, same. Now this is where it stands out. The HDV virus cannot affect the person or infect the person until there is the presence of HBs antigen. If there is no HBs antigen, there can be no infection. If there is, it will present either as a co-infection or a superinfection within 2 to 8 weeks. Superinfection is more worrisome and therefore has a worse prognosis. It can lead to chronic hepatitis naturally, and it will have anti-HDV IgM and anti-HDV IgG virus and immunoglobulins. And both of them, in this case specifically, is for active infection. Then, adding on, I know this was a huge mouthful, so take in some time with this, all right? And come back to this when you have to. I'm going to add on a few more facts about this in the next slide, like hepatitis A. I said there's no carrier state, right? And so the prognosis is good, especially because it's acute. Hep B, there's an acute form and a chronic form. And the acute form it presents on histology as a ground glass appearance. And it presents as a ground glass appearance because the cytoplasm there's a cloudy view to the cloudy appearance of the cytoplasm, and that's basically because there's a lot of HBV proteins, viral proteins, that are found in here. Hepatitis C. Hepatitis C there is an absence of 3,5-exonuclease enzyme. 3,5-exonuclease, sorry, it's going on a tangent, enzyme. And because of that, right here, there is no correction of any errors during the replication process of this virus. So there are multiple genotypes of these molecules. There are multiple genotypes. So our host body or the human body cannot fully be immune or cannot have a foolproof plan against HCV virus. So chronically, it will present as something known as lymphoid aggregates and focal macrovascular steatosis, again, a section which is a concentrate of just fat globules within the hepatocytes, and then lymphoid aggregates placed randomly. One thing you need to know about both HBV and HCV is that they have carrier states, can cause extrahepatic symptoms, and can lead to chronic hepatitis. Hep D infection, because it needs HBs surface antigen, it can be prevented if the patient is vaccinated against HBV. So a lot of times people are pushed towards doing this. Now we're moving on to hepatocellular carcinoma. And finally, what I want to talk about with hepatocellular carcinoma is that it's a malignant tumor which is derived from hepatocytes and any precursor cells. It's more commonly seen in males, and it's caused because of this is not an exhaustive list, but it can be caused because of alcoholic and non-alcoholic liver disease, which will lead to cirrhosis and HCC. Alcohol itself, independent factor. Hepatitis C is a huge factor. azodice, aflatoxin from aspergillosis. There's also Wilson's disease or hemochromatosis. How does that happen? Let's say mutation of, there are multiple reasons. There's genetic factors, which is like mutation of tumor DNA repair genes in chronic hepatitis, because like especially in HCV, because there's so much inflammation and so much mutations that are occurring, there's tumor DNA repair genes get mutated too. Activation of oncogenes that can happen because of damage, because of alcoholic liver disease or aflatoxin. Inactivation of tumor suppressor gene, TP53 being one of them. It is inactivated by HPV virus. So what happens here is that the virus, essentially, when it enters into the body, it inactivates certain suppressor genes and it activates certain oncogenes. So what happens is you have a higher chance of hepatocellular carcinoma. Then there's epigenetic changes, like cirrhosis itself can lead to hepatocellular carcinoma. Grossly, it can either have a unifocal lesion, that is, this is the liver. It can either have one lesion, large and circumscribed with large hard nodule, or else it could be multifocal, that is, multiple lesions of varying sizes, or else it could be diffuse infiltration. So it's all over, right? The liver itself will look light brown, yellowish, or gray. And microscopically, either there's an organized cluster of pseudocanaliculi cells, so you might see bile, or there's a disorganized cluster of giant cells with nuclei protruding, multiple nuclei. And there are multiple patterns in which you can see it. It could be trabecular, it could be pseudoglandular, which is, it's like the acinal glands, but not quite. So they can be solid or macrotrabecular. And while we speak about hepatocellular carcinoma, we also have to speak about hepatic adenoma and metastasis to the liver, because it's very common, metastasis to the liver. Hepatic adenoma is a benign tumor. It can happen within this capsule. So there's a capsule around the liver. Naturally, I am exaggerating. It's very closely bound. This benign tumor will come somewhere between. It's subcapsular. Estrogen is the magic juice, which means that it's usually associated with women on oral contraception, because there's increased amount of estrogen. And so there's increased amount of growth. Increased chances of growth. If it ruptures, if it goes through this and breaks out, there's a chance of intraperitoneal bleeding. So you need to be aware, especially in pregnant women. Metastasis of the liver, very, very common. And the sources can be colon, pancreas, lung, and breast. I'll repeat that again. Colon, pancreas, lung, and the breast. There'll be multiple nodules which are formed. So on physical exam, just like in cirrhosis, you will see a nodular edge of the liver. So be sure about this. All right. And the last and the final pathology of this video and of this topic today, so you've made it till the end, is Ray's syndrome. It's mentioned a lot. It's essentially a fulminant liver failure, similar to where else, just try remembering where else you've seen fulminant liver failure, and I'll tell you at the end of the slide where it is. It's a fulminant liver failure and encephalopathy, which is seen in children with viral illnesses. But it's not the virus itself that causes it, it's the aspirin that they have taken. Aspirin is associated with Ray's syndrome. So what happens is the patient presents with hypoglycemia, elevated liver enzymes, and there's nausea and vomiting because of the encephalopathy. And if the child has a history of taking aspirin because of an infection, it can lead to your diagnosis of Ray's syndrome, and it can also lead to coma and death. So it's a very fatal and emergent situation. With that being said, that's the last one. And I would just like to say, we saw fulminant liver failure when we were talking about HEV virus in pregnant women.